Welcome to The Seasoned Sonographer, the podcast where experience meets education in the world of OB/GYN ultrasound. My name is Lynn Flam, and I'll be your host. I'm a registered diagnostic medical sonographer with over 32 years of experience, most of that time in OB/GYN ultrasound. Through this podcast, I'm here to share insights, tips, and case studies to help you sharpen your skills and optimize your scans. Whether you're just starting out or you're a seasoned pro, this is the place to grow your knowledge and confidence. Let's dive into today's episode.
What is abnormal uterine bleeding? The definition refers to bleeding from the uterus that is irregular in volume, timing, or duration and does not follow the normal menstrual cycle pattern. In reproductive aged women, it includes heavy menstrual bleeding, excessive flow or lasting more than 7 days, intermenstrual bleeding, which is bleeding between cycles, frequent, infrequent, or prolonged bleeding. In postmenopausal women, any bleeding is considered abnormal and must be investigated. The FIGO classification system, PALM-COEIN, is used to identify structural and non-structural causes of abnormal uterine bleeding. Some of the structural causes that we look for in ultrasound, we can use the acronym PALM, P-A-L-M. P stands for polyp, A stands for adenomyosis, L stands for leiomyoma or fibroids, and M, malignancy and or hyperplasia. Some of the non-structural causes are identified by the classification COEIN, C-O-E-I-N. C stands for coagulopathy, O for ovulatory dysfunction, endometrial causes, iatrogenic, which is like medications and devices, and N, not yet classified. Some of the common presentations that patients come into the office with for their ultrasound are menorrhagia, intermenstrual spotting, postcoital bleeding, postmenopausal spotting. Abnormal uterine bleeding can be chronic or acute. It affects both the quality of life and the reproductive health of women. The first line of modality is transvaginal ultrasound for optimum detail of the gynecologic ultrasound. Transabdominal ultrasound is used when the uterus is enlarged or if transvaginal ultrasound isn't possible. With ultrasound, we evaluate the structural causes of abnormal uterine bleeding. Some of the sonographic findings are the PALM or structural findings of causes for abnormal bleeding. Polyps, focal echogenic lesions within the endometrial canal is what we see. They usually have smooth borders. When you put on the color Doppler, you can see a single feeding vessel usually, and they may have cystic areas. Adenomyosis, heterogeneous myometrium, may contain myometrial cysts. They have the Venetian blind shadowing through the myometrium, and enlarged or tender uterus. Leiomyomas or fibroids are well-defined hypoechoic masses. They may be submucosal, intramural, or subserosal. It's those submucosal ones that most likely cause the abnormal uterine bleeding, and they may distort the endometrial cavity. Hyperplasia or malignancy is a thickened, irregular endometrial stripe. An endometrium measuring greater than 4 millimeters in a postmenopausal woman is abnormal. Color Doppler may show increased flow or abnormal vascular patterns. We can also see some ultrasound findings from those non-structural causes of abnormal uterine bleeding, like ovulatory dysfunction or abnormal ovulation. The endometrium may appear thick and echogenic due to unopposed estrogen. Often there's no structural abnormality seen. One of the iatrogenic things that is seen with ultrasound is a malpositioned IUD can also cause abnormal uterine bleeding and pain. Always measure the endometrial thickness in the sagittal view. Measure including the trilaminar layers of the endometrium. Depending on the point in the menstrual cycle, the endometrium may look differently, but always include the trilaminar layers if you can see those. Describe the shape, echotexture, and intracavity content. Note any distortion, fluid, or disruption of the endometrial myometrial junction. If there is fluid within that endometrium, make sure you don't include that in your endometrial measurements. Measure the AP portion first, and then the posterior portion of the endometrium, excluding that fluid. Measure the anterior part of the endometrium, and then measure the posterior part of the endometrium without the fluid, and then you can add those together, and that's the true endometrial thickness. So a quick recap on the ultrasound findings are polyps, focal mass with a feeding vessel, adenomyosis, heterogeneous myometrium and cysts, fibroids, they're solid, well-defined masses. Location matters. Those submucosal fibroids are the ones that usually cause the heavy bleeding. Hyperplasia or malignancy will show a thick, irregular, possible vascular endometrium. Some of the non-structural, the ovulatory dysfunction, thick but uniform endometrium, and then a malpositioned IUD can cause the abnormal uterine bleeding. Key takeaways. Always correlate imaging findings with age, history, and menstrual pattern. In postmenopausal patients, any bleeding requires evaluation. Clear, complete documentation from sonographers supports accurate diagnosis and appropriate care. Let's explore how these findings guide patient care. I'm joined by physician assistant Logan Colvis, who works in women's health and brings the provider's perspective on evaluating and managing abnormal uterine bleeding. Logan, thanks so much for joining us.
Thanks for having me.
Can you start by telling listeners a bit about your background and your role as a PA in caring for GYN patients?
Yes. So, like Lynn said, my name's Logan. I'm originally from Chester, Illinois. After I graduated high school, I went to Murray State University, where I majored in biology and chemistry. And then I went on to go to PA school at the University of Evansville in Evansville, Indiana. And then this was my first job out of PA school, and I've loved it. So my role here is I work a couple days in clinic, and then I work a couple days in the OR assisting with surgery and C-sections, and I love it. It's the best of both worlds.
I was going to say, it's a good combination for you.
It is, and it is a great gig where I get to apply what I see in surgery to what I see in clinic, which helps connect all the dots, because you kind of don't really get to understand, like, you know, I mean, you see the uterus
right
in a textbook, but until you see it in real life, you're like, oh, wow. Like,
there it is.
There it is.
In the flesh, literally.
That's what that does.
Yeah, right. So today we're talking about abnormal uterine bleeding. And when someone presents with abnormal bleeding, what is your first step in working them up?
Yeah, so I think the very first thing that you should do is look at the patient's age. Because how I approach a 15-year-old is going to be different than how I approach a 55-year-old. So, for example, if I see a 15-year-old, I might think, okay, abnormal uterine bleeding, some typical things could be, is their hypothalamus, pituitary, ovarian axis off? So, in layman's terms, are their hormones not regulating how they should be regulating? Or is this just like some immaturity? Because within those first couple of years of having your period, you kind of have some immature bleeding. Mm-hmm. Now, in like a 55-year-old, I would be more concerned about, okay, is this fibroids, endometrial cancer, polyps, those hyperplasia, those things where I wouldn't necessarily be concerned in a 15-year-old. So the age, to answer your question, is kind of the first place I start.
And then, do you always order an ultrasound right away, or do you sometimes just start with the medical management?
So I think that's where kind of age plays into a part there. In kind of our younger patients, I start more with medical management or labs. Mm-hmm. And then, you know, anywhere probably after 35, depending on some comorbidity factors, 35, 40, then I revert to the ultrasound first. before management with medicine.
So let's move from the exam room to the imaging side. What do you look for in a good ultrasound report when someone has abnormal uterine bleeding? What are you looking for in that report that's going to help you counsel that patient?
So I think that with any imaging, the way we're taught is you should have a stepwise approach to how you look at ultrasound. So for me, I like to look at the uterus and the endo first, which is two really important parts with abnormal uterine bleeding. You're kind of looking at, okay, with the uterus, do they have leiomyomas? Do they have adenomyoma? And then with the endo, you're looking at the thickness. And a lot of that comes from the report, kind of what you guys tell us, what you guys are seeing as well. And then after that, you look at your ovaries to see if there's lots of follicles. You look at free fluid. But those are the kind of the major points that you hit in a pelvic ultrasound. And I think it's important to always kind of have a stepwise approach at what you look at first should always be the same, so you don't miss anything.
Right. So you go systematically through that report, through things in your mind that might be causing that bleeding. Do you prefer that sonographers describe fibroid location or comment on that endometrial detail? Because I know that sometimes sonographers do not report that.
No, I think it's really helpful, especially from a surgical standpoint. So let's say a patient has a polyp or a fibroid in their uterus or in that lining. From a surgical standpoint, it's very helpful because is it manageable to get through a hysteroscopy, which is a type of a surgery we do, or what type of surgery do we need to schedule for this patient? So location definitely matters, especially from a surgical standpoint.
Sometimes imaging confirms what you expect, and sometimes it completely changes the plan. Can you share a case where the ultrasound completely shifted your diagnosis and you're like, oh, she's got a polyp, or oh, she has a submucosal fibroid?
Yeah, so I actually had a patient earlier this week where this patient was bleeding a lot. So they were bleeding 2 periods a month or so. And so usually when I have that in my mind, I'm thinking more of fibroid, polyp, or hyperplasia if it's a really bad bleeding. And this patient in particular ended up having PCOS. So without having an ultrasound, I would have never really PCOS is on the diagnosis, but it's very low, like maybe 5, 6 on the diagnosis, because usually people with PCOS have no periods or amenorrheic. And so with ultrasound, I kind of moved that diagnosis way up. So that was just a case this week where I was like, oh wow. So without ultrasound, I probably never would have until later on evaluated or looked at PCOS. So that was one recently.
Yeah. And what do you do if the patient comes in, they have abnormal bleeding, you order an ultrasound and the ultrasound is normal? Then what do you do?
So then I usually try to look at, okay, what have we missed so far? So you kind of go back to that PALM-COEIN that you talked about earlier, and you think, okay, have I looked at the patient's thyroid? Have I looked at the patient's blood work to look at coagulopathies that we miss typically? And then, if everything that you kind of look at is like, okay, everything seems normal, then maybe let's hit some medicine management. And not all medicine management works for people, so just because maybe an oral birth control didn't work doesn't mean that an IUD or a shot or other oral birth controls wouldn't work. So that's kind of my stepwise approach is, okay, take a step back. Take a step back and look at, the PALM-COEIN again. What have we hit? What have we not hit? And then, if we hit everything and we still can't figure it out, then I usually try a different type of medicine. And then after that, then depending on the patient's age, we can move towards biopsy or surgery, or just, I kind of kick it out to our doctors to see if they have any advice.
Right. Yeah. So when do you add a biopsy or the hysteroscopy or a saline-infused sonohistogram to include that in the workup?
Yeah, with the biopsy, we typically try to avoid biopsying under 35. And so anyone who's above the age of 35 who also has some of those comorbidities, so higher BMI, high blood pressure, different stances, like so PCOS is another one. Then if they're over the age of 35, a biopsy is indicated. And then anyone over the age of 45 who is having abnormal bleeding that's not controlled with medicine management, if they fail the medicine management, then we would recommend biopsy.
Let's talk about how you communicate these findings with your patients. How do you explain something like a thickened endometrium or a polyp or fibroids in plain language?
So for the endometrium, I like to describe your endometrium like your lawn, so grass. And so similarly to the way your grass grows, your endometrium grows. So your body has two main hormones, or a female's body has two main hormones, estrogen and progesterone. And so estrogen is like fertilizer and progesterone is like a lawnmower. So estrogen is going to make your lawn or your endometrium grow really thick. And then that progesterone is going to come and cut the lining off. That's why you have a period, is when that progesterone surge happens. So I like to describe the endometrium like your lawn.
Yeah, that's a good analogy. I like that. I'm smiling. I'm going,
I love that analogy.
Yeah.
And then polyps, I like to describe as skin tags. So, because you can see a skin tag, you can't see a polyp. So like your skin grows a growth or a skin tag, I say your endometrium or your uterus does the same thing. It's usually benign, kind of like a skin tag, but it's just like free floating, kind of like it does on your skin, and it's just a growth. It's just kind of a growth of tissue or a growth of skin.
Right. What fears or misconceptions do you think patients have about uterine bleeding and even some of those benign growths?
Yeah, especially with the benign growths, I think that when you tell someone they have a mass or some type of growth in their body, their mind automatically kind of goes to cancer.
Right.
And so, and it should. I mean, it's scary, but I think trying to reiterate to patients that most of these fibroids, most of these polyps are benign. And so that's kind of where the surgery management comes in, is if they are worried, we can take it out, we can remove it and biopsy it to kind of ease their mind.
Right, and it also depends, I'm thinking about ultrasound, it also depends on if some of these things have vascular flow to them.
Exactly.
It depends on if they cause bleeding and things like that. So we love working closely with providers like you. So let's wrap up with some pearls. What makes for a great collaboration between the sonographer and the provider?
Oh, well, Lynn, I love working with you. I think just having an open communication and trust, right? So when you trust someone, because you're our eyes, you see it. A lot of times you see the images and they don't get reported back to me until weeks later. And so having a good sonographer that you can trust, that's going to catch little things like our ectopics that we catch a lot, is important. So that trust is really important.
What advice would you give new PAs or providers entering women's health?
Yes, I would say this is a field that you have to be super passionate about, because it's a field that requires lots of hours, and it's a very delicate field. So there's a lot of times, your patients are in the most vulnerable state of their lives. So pregnancy, it's a new thing. It can be an exciting thing. It can be a scary thing. So being really passionate about it helps navigate those big feelings with patients. And so it's something I would really recommend. If you're not passionate about it, it would not be the field for you. But it's also a field that's so rewarding. You get to look at the whole lifespan of a woman. So the time that they start their period, and then they have their first kid, and they're pregnant, and then menopause. It's like one of those fields where you have the whole lifespan of someone, and that's not what a lot of fields other than family med get to do.
That is so cool. Logan, thank you for sharing your insight today.
Yes, thanks for having me.
For sonographers and providers alike, remember your scan is often the first key step in uncovering the cause of abnormal uterine bleeding. Clear imaging and clear communication drive the best care.
Thank you so much for joining me for this episode of The Seasoned Sonographer. If you're interested in improving your OBGYN ultrasound skills and learning more about the field, make sure to subscribe to The Seasoned Sonographer on Apple Podcasts, Spotify, and YouTube. You don't want to miss any of the upcoming episodes. You can also connect with me on Facebook and Instagram at Sonotechniques Academy. Explore more educational resources on the Sonotechniques Academy app or reach out via email, lynn@sonotechniquesacademy.com. I'd love to hear from you. If you have questions or topics you'd like for me to cover, feel free to reach out. This podcast is for you, and I want to make sure I'm covering the topics that matter most to you and to the ultrasound community. Until next time, keep striving for excellence in your scans, and I'll see you in the next episode of The Seasoned Sonographer. The information provided in this podcast and any accompanying materials is for educational and informational purposes only. It is not intended as a substitute for professional medical advice.